Well, our core conversation of the day, lifestyle diseases and how that is looking in this season of COVID-19. And to help me have this conversation with me in studio, Dr. Elijah Njao, who is a cardiologist from Nairobi Hospital. We have Dr. Alex Mogere, who is a physician with AAR in our studio here. And we also are joined by Lucy John Bosco, all the way from Tanzania, who is living with type 1 diabetes and who is also an advocate of the same. Thank you for joining us. Now, I'll start with you, Dr. In as far as lifestyle diseases are concerned, just define for us what are cardiovascular diseases, maybe comorbidities is what we keep hearing in these sentences and, of course, presses. What are they?
Good morning, East Africa. So for girls, you're asking me what lifestyle diseases are. And lifestyle diseases are diseases that come or accrue just because of the way we live. And most of those diseases are the things that we actually come because of the things that we do. Meaning they actually cover a whole spectrum, but the cardiovascular diseases are usually one of them. And those cardiovascular diseases, they are things like hypertension. They are what we call coronary artery diseases. That's the time that we talk about people having a heart attack. There are other diseases that we call like atrial fibrillation. That means the heart tends to get other arrhythmia. The heart has the normal way it beats, but you actually find that because of the things that happen or the things that we do, you find that the heart beats abnormally. And that usually comes because of a result of other things that we do, like people who smoke, people who take alcohol, and that is what we actually find. Of course, the other lifestyle diseases, we have the one that affect the lungs, like the one that come because of people who smoke, like what we call COPD. There are many people who have COPD. You also have people who have asthma. Some of them, they're actually related to the lifestyle, to how people live, what they do, what their occupations. All those, we actually call them lifestyle diseases. And of course, not forgetting cancer. Then the other major disease is actually obesity.
Yes.
Okay? Obesity is also a lifestyle disease. It's a lifestyle based on how you eat, what you eat, and generally how you live also. What kind of a life do you lead? There are people like now in the way that we live in these cities, or the way we live in the urban areas, we actually find that we live a sedentary life. A sedentary life means that we are not active, we don't walk, we spend more time on the screens even from like what you have here.
Yeah, my computer.
Your computer, your TV, phones, all those simple things that actually bring those kind of diseases. So it's a whole spectrum of diseases, but affecting all the parts of the body.
Okay, now before you tell us how the patients with these diseases are susceptible to getting COVID-19, if you're just joining us, the conversation, COVID-19 and lifestyle diseases, and as Dr. has mentioned, these are associated with the way a person or a group of people lives. Now, lifestyle diseases include heart disease. They actually can lead to a stroke, obesity, type 2 diabetes, hypertension or high blood pressure, just to mention a few, and diseases associated with smoking and alcohol and also drug abuse. However, regular physical activity helps prevent obesity, heart disease, hypertension, diabetes, even some cancers, and premature mortality. So, Dr. tell us, what about these patients makes them susceptible to COVID-19?
Okay. There are several factors that actually lead to that. And the major factor is actually the age. You actually find that most of the lifestyle diseases, they actually happen as we age. I think it's actually a matter of how much of that dose do you accrue as you live longer. If you started smoking, by the time you are 60, you started at 20, you actually have more effect of that when you're in your 60s rather than when you're in your 40s. So actually the age is actually one of the major factors. And you actually find that as we age also, the other thing that happens is that our immunity tends to go down. Okay, for everybody. So that you even find that as people age, you actually find that a infection that will probably not have affected you when you're in your 20s and your 30s, and then you are around your 60 or your 70, you find they are easily able to actually come and attack you. Of course, the way to do is that it will take longer for you to get well from a disease. And number two, you actually probably require more admissions because the body needs to be helped to actually overcome that. Your immunity is actually so susceptible that you need help. And that's why now as doctors come in, that we are there to actually give you the medicine that will actually help your body to fight off the infection.
So are we saying only those who are plus 55 are susceptible? If anyone has all those lifestyle, it does not keep their lifestyle well and makes them susceptible to conditions. Are you saying if you're younger, you're not susceptible?
Of course, what usually happens that as you get older also, the people who are older and they have the lifestyle diseases, they are more susceptible than the same age group or the same age mates who do not have the chronic illnesses. So you actually took like a 60-year-old person who is diabetic and one who is not diabetic. But the way they handle infections will actually be different. You take one at the same age, one with cancer and another without cancer, one with heart attack, with heart failure, and another without heart failure. They're actually going to handle those things just because of the mechanism of the body happens. And you find that the people who have those morbidities, that means those lifestyle diseases, their way of fighting diseases, including the viral infections, of which COVID is one of them, bacterial infection, is actually different. They are much less able to handle that compared to people who do not have. So you're correct to say that patients who have those lifestyle diseases, they're actually more susceptible. And that has actually been shown all over the world. And you actually find that for those people who get COVID and they have those other chronic diseases, they are actually likely to get more severe infection. Like you actually know that most of the, around 80% of the people who actually get will probably be asymptomatic. But we have another 20% who actually get mild infection when they have COVID. And another 5%, 2 to 5%, based on what part of the world you're looking at, who actually get severe infections. Those are patients who actually who get very severe infections. They will actually need ICU admission, and probably those are the group that are actually dying. And we actually find that those patients now who have those kind of conditions, they actually who have chronic illnesses, they're actually the one who actually fall into that category.
Okay, now let's bring in Dr. Alex Mogere, who is a physician, and we have more men than women contracting and actually succumbing to COVID-19. Is this in any way an indication also on how the distribution or prevalence of lifestyle diseases is in the genders, male and female?
Thank you, Gladys, for hosting me. I think it is important to mention that between males and females, we have different health-seeking behaviors. You find that for most lifestyle diseases, for example, you get men affected more than females, and largely because of exposure and also behavior. Right now, as we have seen the different statistics coming from different parts of the world, men are affected more than the females through this COVID-19 pandemic. And largely it is because of the health-seeking behavior, which is a bit strange and interesting in the sense that when you look at how interested people are in looking at their own health matters, you find that males fall behind the females. So we are more likely to have males suffering from diseases more than females for various reasons.
Okay, but we had a research done the other day that actually indicated there are more women who are obese than men. Explain that.
Well, yeah, that is an interesting observation, and there are several factors that may contribute to obesity. One is physical activity. So there is also a likelihood that women may be more inactive in the sense that most of their activity, whether at home or at work or whichever other place, generally speaking, they may be less active compared to men. But also hormonally, they may also have a little bit of a predisposition. And this is because when you look at their basal metabolic rate, it's known that women have lower basal metabolic rate than male, generally speaking. So some of these things may actually affect some of these lifestyle diseases such as obesity. And you may find variations such as that just because of the different behavioral patterns in the different groups of people.
Now, Dr. Alex, you talked about health-seeking behavior, and that has changed especially during COVID-19. Is this the case at AAR?
Well, it's interesting. Around this time, it's sad to note that, of course, the health-seeking behavior has changed, and it is not necessarily positively. We have people putting more attention to contracting the COVID-19 and forgetting that we also have other conditions that we need to be looking at. And as we've said, lifestyle diseases are diseases that are here with us. They are going to be around and they need to be taken care of. And it's also known that lifestyle diseases actually cause more deaths than most of the infectious diseases that we have. So it is important that our viewers and our patients get to know that for now they have to follow on their health regularly, and they need to be up to speed. So right now, as we look at the behavior and the visits, for example, the visits have definitely gone down, and largely it's because of the fear of contracting COVID-19. And clearly, this is at the expense of other lifestyle conditions. Diabetes, hypertension, cancers, and other conditions need to be followed up. So it is important for our patients to know that even as we go through this pandemic, that they also follow on their other medical conditions. Because unlike COVID, which may give you symptoms and effects immediately, most of these lifestyle diseases become progressively worse as you go. And unfortunately, you're not necessarily able to tell whether things are going wrong until you have gone to the clinic for, say, checks of your sugar, your blood pressure, and also to see whether there is any complication that is going on with other organs and systems.
Okay, so, now speaking of prevalence, the WHO has actually said diabetes and hypertension is becoming quite a burden, especially for Kenya, and would like to look at those two. And starting off with diabetes, Khadija Abdul, a high school student, has been suffering for more than 5 years now. She narrates her life living with diabetes with an understanding that it is a controllable condition. She paints a picture of the young face of diabetes.
My name is Khadija Abdul. I am in Form 3. My best subjects are history and science.
And you see what you get.
I would like to be a journalist. I've been diabetic for 5 years right now. I used to urinate a lot, get tired, thirsty at all times, hunger. So my mom was told by her friend that maybe it might be diabetes. My mom's friend, since she was diabetic, she tested me with her glucometer, and then they found out that my blood sugar was high. So I was taken to hospital. And from there, I had medications until I was discharged. I was 12 years. They couldn't tell me in details, but they told me that I wouldn't be able to take sugary things at that time. So I couldn't understand. I was really angry. And then, like the doctors, as they were monitoring me and stuff, they told me that many children are living with diabetes like me, and I got a chance to meet all of them, and they gave me their storylines. So then I just tried to accept it. My mom was the one who was doing it, at times my cousin, and then like I went to hospital during the checkup. They told me that at some point my mom might not be there, or whoever was injecting me, since I had support from the nurses. So like I would just go every single morning, I go there, inject myself, then go for breakfast. In the evening, I do the same. The people who knew that I was diabetic were only my closest friends and my classmates at some point. And I never wanted them to tell many people that I was diabetic because I was fearing that I might be discriminated. My message to the young people is that diabetes is a controllable condition. They should not fear it. If I live with diabetes and I'm okay, then they can. Surely they can.
Very powerful message there by Khadija. A diagnosis of diabetes is not the end of the road. And speaking of which, we are also joined by Lucy John Bosco, who is living with type 1 diabetes all the way from Tanzania. Lucy, when were you diagnosed with diabetes?
20 years ago.
And how old are you so that we can do the difference?
33.
And what brought about the diagnosis? What were the symptoms?
Oh, okay. Luckily, I knew diabetes symptoms before I got diagnosed. So I had to drink water a lot, especially at night. Having the going to toilet for short call every time, especially at night. So I decided to test my urine, because they said once you are diabetic, then the urine will taste very sugary. So when I tested, and it was like, I tested all the sugar in my urine, I called my mom. By that time I was in school. I started in Uganda. So I called my mom, I told her what happened, then the process of coming back home started, but I never make it through Dar es Salaam, because I went in the coma when I was on my way.
Wow.
Yeah, so after like 3 weeks, I woke up, I found myself in Mount Mary Hospital in Arusha.
Okay,
Yeah, so
at 13 years, at 13 years of age, what made you, I don't know, what gave you information about diabetes? Is it in your family?
No, it's not in my family, but my mom, she's a nurse, midwifery. And during weekends, she used to go at work. So at a national hospital, Muhimbili National Hospital. So our office was nearby the Tanzanian Diabetes Association. So when I'm going with her during weekends, I used to like pray around the office and all that. So I used to see the signs and like everything. So when it happened to me, I was like, oh my God, maybe it's diabetes. That's why it was so easy for me to know it is diabetes.
Okay, so Dr. Lucy touches on some of the symptoms she was feeling. First of all, define for us, what is diabetes?
Diabetes is a disease where the body is not able to handle sugar. So you find that what happens when you actually do a blood test, you find that there's too much sugar in the blood. When you eat, the body should actually take up what it needs to use. Then the rest of it takes away. But in this situation of diabetes, what usually happens is that the body is, two things happen. Like for Hadija, she's type 1 diabetes. That means her pancreas is not able to produce any insulin. Actually, very little. It produces very little insulin or none. That's what we call type 1 diabetes. We have the type 2 diabetes, which now happens after the age of 40. We actually say after the age of 40. That means that the people who are adults. In that situation, what happens is that the body produces little insulin, that is, it produces insulin, but it is not enough for the body to utilize what you call the glucose in the blood. Then there's also another mechanism in type 2 diabetes, in that the body produces the insulin, but the body is not sensitive to actually take up that insulin. Those are the two types of diabetes that we usually have.
So Lucy has type 1 diabetes. The young girl, Khadija, also has type 1 diabetes.
Correct.
So this is one that you're born with.
Yeah, it's not that you're born with. You can be born with, or sometimes it develops when you're younger. Okay, and that's what we are talking about. Your pancreas not able to produce very little insulin, to produce very little insulin or no insulin at all. And that's why even for them, the treatment is that they need to supplement the insulin that the body is not able to produce. And the symptoms that happen with that is that what happens is that you have too much of the insulin in the blood, it must come out. The way it comes out is that it comes out through the urine. When it comes out with the urine, you find that it's like the way if you put sugar somewhere, it pulls water into it. That's the same way that happens even with that sugar in the urine. So it pulls water out into the urine, and you find that they need to urinate a lot of time. So the more you urinate more times, the more you get thirsty. And that's why even when you had Khadija say that, even Lucy, that they needed to drink a lot of water. Just because you pass a lot of water, so you actually need to replace the same thing.
But she also mentioned when she was being transferred from Uganda to Tanzania, she went into a coma. What would cause that? So
that is actually a condition that we call diabetes ketoacidosis.
What is that?
That one happens when you have actually had a high sugar for a long time. And what happens is that you tend to lose, as you pass urine, you actually tend to lose what you call electrolytes. Electrolytes are those things that we call them ions. Remember those things that we used to do in chemistry?
Yes.
Sodium, potassium, calcium. You tend to lose all of that. Mm-hmm. Then number two, what happens that once you lose a lot of water, you also become dehydrated, and that affects your brain. Your brain tends to actually be like dehydrated. That means it's dry because you have actually pulled the water from the body, and that's why patients usually go to that coma. And that happens when you actually have no insulin. That means your cells cannot take up any glucose, so they are not able to actually metabolize. Metabolize means they are not able to use that one to give you energy to have the normal cellular function that happens anywhere in any organ. And if that happens for a long time, you actually find that one goes into that coma.
Okay, now Lucy, it's been 20 years and you are healthy and thriving. What did you have to do on a personal capacity to adapt to living with type 1 diabetes?
Okay, I think people who maybe are newly diagnosed with diabetes, they have to know how to live with diabetes. Because having diabetes is one thing. How to live with diabetes is another thing. They say, put your friend closer, but put your enemy more closer. Because diabetes is like an enemy who can destroy your life. So you have to read that enemy. You know, what to do, what not to do, what to eat, what not to eat. You have to know your limitation. So in Tanzania, I don't know in other countries, but in Tanzania, there's a lot of misinformation about diabetes, especially when it comes to what you're supposed to eat and what you're not supposed to eat. So when I finished my Form 4, I decided to take short course of diabetes counseling and nutrition because I love to eat and I love to eat good. So I wanted to know what am I supposed to eat, what I'm supposed to avoid and all that. So after finishing that course is when I knew it's like, okay, it's not what to eat, it's how you eat what you want to eat. That's why I'm looking healthy, and I've been volunteering teaching people about diabetes, especially on the angle of how you're supposed to live with diabetes in order to avoid diabetes complication.
Lucy, I'm sure people listening to you are wondering, what do you mean by what you're supposed to eat?
Oh, okay. For example, I would like to refer in Tanzania because I know much about here. I don't know about other places. So in Tanzania, most people with diabetes, they're being told that you're not supposed to eat starch only because starch or carbohydrates produce sugar. But fine, we have diabetes. We also need starch in our body, but we don't need to have a lot of starch. You see, so you have to know that the amount of starch that you're supposed to take in. If you're used to eat a large plate of rice, so you have to eat only single serving spoon of rice, or only 2 series of bread. That's what I'm saying, that you have to know how you're supposed to eat what you want to eat. And also you have to like check your blood sugar every time. If you have the equipment, strips and machines, you have to check maybe 3 to 6 times so that you can know how am I supposed to eat the food that you want to eat.
Okay, Lucy, I'm sure we'll be elaborating on that more even as we go along. I am told we are now joined by Patricia Katunga, who is living with diabetes, and she is right here in Nairobi's Kibra. Patricia, asante sana kwa kujiunga nasi. And we are also joined by Evans Nyabega, who is actually hypertensive, another condition that we shall be looking at that is a lifestyle condition. Now, Patricia, nitaanza na wewe. Ulijua siku gani ama mwaka upi ulikuwa na diabetes?
Nilijua 2016 December tarehe 25.
Ulikuwa na miaka ngapi?
2016.
Ulikuwa na miaka ngapi?
Nilikuwa na miaka nilikuwa na 53. 52.
Na walikuambia una diabetes ipi?
52.
Walikuambia una diabetes ipi?
Sasa wakati huo kulikuwa na outreach. Wakunieleza ni gani, walinituma Bagathi.
Alafu kule wakakwambia una ipi?
Wakaniambia waniambia ni step 1 ama ni step 2. Waniambia sijui ni step 2.
Ehe. Na sasa unaishi vipi? Unatumia insulin ama ni kuangalia kile unakula?
Natumia dawa, na punguziwa chakula, natumia tu madawa, na kunywa asubuhi na kunywa jioni, natumia tu tembe.
Kwa hivyo hujawahi tumia insulin, eh?
Nilitumia mwanzo lakini sasa natumia tembe.
Aya, sasa kwenye jamii yenu kuna yeyote ambaye ako na diabetes?
Wasasi walikuwa naye, brother yangu wawili wako naye, wasichana 3 wako naye.
Aha, kwa hivyo vile uliambiwa unaye haukushangaa?
Nilishangaa kidogo sababu mimi nilikuwa mwembamba, nilikuwa nafikiri wale na wavata sababu ni wanono.
Aha, okay, sawa. Now, Dr. Mogere, she brings up a bit of the myths and misconceptions when it comes to diabetes in as far as how it looks like physically. Please bust some of these myths for us.
All right. Well, thank you, Gladys. When it comes to diabetes, of course, many people who have said things about diabetes, many of them are informed, many are ignorant, but I think it is important for us to know, even as we go along, that when it comes to diabetes, like in this country, it is very sad to note that majority of our patients who may have diabetes or a condition that we call prediabetes, which is a condition that precedes diabetes, almost 2/3 have no idea that they have diabetes. And that's why we talk about the importance of screening, so that the diseases can be picked, or this diabetes can be picked. When it comes to the things that one may present with, one has already mentioned the issue of thirst, excessive appetite, passing a lot of urine. Physically speaking, when you look at a patient with diabetes, it really depends on the stage at which this patient presents. You may find that there's really nothing much that you see in this patient, but the patient may experience a couple of things, which may be complications that arise from high sugar levels. One of the things that the patient may present with includes, one, problems with their nerves, a condition that we call peripheral neuropathy. So the patients may have a tingling or pins and needle sensation, which may arise in their hands or in their feet. Patients may also begin to lose hair in their legs, especially if we have problems with circulation, because one of the other complications that is associated with diabetes is a condition that we call peripheral arterial disease, where with reduced circulation and therefore reduced nutrients to the skin and different parts of the legs, we are going to very likely lose the health and the integrity of the skin, and therefore loss of hair. Now, for some who, especially for the type 2s, you find that during the early stages of the disease, even as the disease progresses, a good number of people may lose weight. All right. So you may have that as one of the symptoms, and therefore important for people to look into that. But then as diabetes progresses, especially if it is not picked early, then it causes other bigger complications. And this is now when we have problems with the eyes, problems with the heart, and this is where we talk about the risks that Dr. Njau was talking about, which are the cardiovascular risks. And these patients with diabetes are highly predisposed to the cardiovascular risks that include coronary artery disease with heart attacks and strokes, and patients may also develop heart failure, and features of heart failure include intolerance to physical exertion, where a patient has problems with taking a flight of stairs or going up an inclined slope or things like that. So when it comes to diabetes, the symptoms may not necessarily be very obvious. You may actually be looking normal, you may feel nothing, and only when you get to a hospital that you find that incidentally you have high sugars. And that is why we say it is always important, even when we don't feel anything, that we actually get to our hospitals to just have a few things checked. For example, the sugar and the blood pressure. Let's not just think that just because we are okay, we don't feel anything, that we are fine. Even a vehicle is not always okay as much as it feels okay when you take it to the garage. So it is important that we get to realize that it's not always that you'll have symptoms or signs.
Okay, now back to Patricia. Patricia, ulikuwa umenieleza ulipata stroke na pia unaishi na hypertension. Ulipata stroke mwaka upi?
Stroke nilipata 2019 mwezi wa 3.
Na ilitangulia
nilipata stroke na ilitangulia, nilianza kuumwa na kichwa, sikukuwa najua kama niko na pressure. Nilianza na kuumwa na kichwa, ikaniuma usiku na mchana ikiwa itulii. Sasa wakati huo nikalala, kuamka asubuhi nikawa nimepula ulime, mdomo imevula, macho imepura, yani nikawa seti moja sioni na mdomo imepinduka. Sasa kwenda Kenyatta ndio niliambiwa ni stroke. Ndio walikanifanya x-ray. Pressure kupimwa ndio ilikuwa juu. Ndio nikaanzishwa dawa za pressure. Sikuona nikipewa dawa za stroke. Nilianzishwa tu dawa za pressure. Mdomo ikaanza kurudi pole pole mpaka saa hii imerudi. Lakini hiyo macho seti moja inakuanga ina shida.
Okay, and daktari,
natumia miwani.
Asante. Daktari, she's talking about the complications. What is the relation between diabetes, hypertension, and now a stroke?
Okay, now thank you, Gladys. So you see, like now what we are talking, those are the myths that we actually talk about. And like Dr. Alex said, even like before one, like for type 2 diabetes, before one is diagnosed, you actually had the diabetes for probably what we know is actually between 5 to 10 years by the time you come to get diagnosed. And that means that most of the patients will actually, most of the people will actually present with symptoms 5 years down the line after the diabetes started. And that's what we actually say, like what Dr. Alex said, that the emphasis that after the age of 40, we always recommend that you probably have your sugar checked annually. The blood pressure, the same way after the age of 40. The myth is that like now for Patricia, you see, she got a stroke, but she didn't know that she didn't have hypertension. The bad thing about hypertension is one, that you have high blood pressure, but it doesn't pain you anywhere. So that by the time you're coming to know about the hypertension, it has already caused you damage. And like for Patricia, it was unfortunate that what actually developed is that she had the stroke, unfortunately. And that's usually for most of the people you actually find, that is the first symptom that they have, sign that they have hypertension.
Okay, why don't you define for us what hypertension is in this case? It is called high blood pressure. Yes. What exactly causes it?
The hypertension, for hypertension, we say that the causes are many. There are very, very many causes. But the first major thing that causes hypertension is actually age, like I said. And all over the world, research has actually been shown that after one reaches, of course, we have two types of hypertension. Okay? We have what we call primary hypertension and secondary hypertension. Yes. It's easier to remember because we all went to primary school and went to secondary school. So the primary hypertension is the one that we actually say it's the one that happens with age. Why it's called primary is because it's actually not caused by anything in particular, but actually by the changes that happen as one ages. What happens is that there are those changes that happen with aging. And those changes that happen that with the blood vessels, when you're a baby, the vessels tend to be like a balloon. The heart pumps the blood through the vessels, and they are easy to balloon out. So that means there is a passage of blood through the vessels. But it has actually been shown that from the age of 20, or even probably a little bit earlier, around 15, 14, you actually that there are those little changes that happen on the vessels. And based now on the other things that happen, whether you smoke, whether you are obese, whether you are diabetic, or whether you have all the other risk factors, it can happen earlier for you. But by the age of 40, most of the people you actually start finding that those stages that have actually happened, and now they are actually starting to give you pressure. Why do you say the age is actually one of that factors? Is that when you actually look epidemiologically, that means when you actually go to the communities and look at what is the prevalence or that what is the size or the burden of hypertension in the community. What you find that is that by the time one is around 50 years, you actually find that like around 30% of the people have hypertension. By the time now you are probably in your 60, 40%. By the time now you are probably in your 70, 80, you actually find that almost like 60% of the people are hypertensive, just because of the aging. Of course, there are other things that we also do that actually contribute to one getting pressure, and those are things like smoking, even alcohol.
You mentioned secondary hypertension.
Yes. Then the secondary hypertension, that is the one that we actually see a little bit earlier in age. And we call it secondary because there is a cause, okay? There's a cause to the hypertension. And those are the pressure that hypertension that we see below the age of 40. And the causes that we actually know that bring that are the issues with the thyroid issues, okay? Whether your thyroid is overworking, what we call hyperthyroidism, or hypothyroidism. That means your thyroid is underworking. Number two are the kidney diseases. There are patients who develop kidney diseases, and if they have kidney diseases, it will actually, because the heart and the kidney work in like in cities, okay? You find that if you get develop a kidney disease, it has to be a little bit harder for the heart to push the blood through the kidneys. So actually that means the heart must work a little bit harder, and that's what we call pressure. Okay. Then there are other things that we call you call endocrine diseases. Things like patients who have adrenal issues. Adrenal is actually one of the adrenal gland is one of the glands that's actually found on top of the kidney. Long time ago, when we used to be in school, it used to be called suprarenal. That means it was used to be found above the kidney. But so if they're actually having the adrenals overworking, then that's one of the other things. The other thing that we have is narrowing of the vessels that go to the kidney.
Okay.
That's what we call artery stenosis. So those are actually the secondary causes. The good thing about the secondary causes is that if you're actually able to handle them, to treat them to completion, you actually find that your pressure may actually go away. And that's why we actually say it's a secondary cause, because it's brought by something else.
Okay, let's bring in Evans Nyambega, who is hypertensive. Evans, when did you find out you were living with hypertension?
Thank you, NTV, for inviting me to the studio today. It is very difficult to tell when I first felt hypertensive, because it doesn't give you any signs. It only comes in the process of the attack. So around 10 years ago, I suffered hypertension, and as a result, I had heart attack and a stroke.
Okay, and at that point, did they tell you maybe you had other pre-existing conditions, maybe like diabetes?
Sorry?
Do you have any other condition apart from high blood pressure? Was there any indication of maybe diabetes?
Yeah, I've already indicated that as a result of this hypertension, I suffered stroke and heart attack.
Okay, and in your family, anyone who's ever lived with hypertension before?
Yeah, I can recall, this is much later now.
Yes.
My father died in 1980. So he died under such circumstances. So my mother dies 20 years later, and she suffered from diabetes. So I can say My family has this hierarchy of problems.
Okay, Evans. Now, Dr. Mogere, before we take a short break, in the case of Evans, it sounds like these diseases we're talking about could easily be in the family lineage and you could get one or the other. Is that the case?
Thank you, Gladys. It's important to know that when it comes to lifestyle diseases, heredity is actually a possible risk. In fact, broadly, we usually classify the risk factors for these lifestyle diseases, and in this case here, talking about hypertension, into what we call modifiable risk factors and non-modifiable risk factors. So the modifiable risk factors, as the name suggests, means that you can actually do something about it to actually correct the problem. Non-modifiable risk factors include heredity, the age, race, and so on. So it is actually possible for it to run in a family. In fact, for most of our patients, whenever we ask them whether they have a family history, some will actually tell you they don't. But unfortunately, like I said earlier, the health-seeking behavior, especially of Kenyans, is a bit interesting in the sense that you actually may find that some people have actually never gone to have a blood pressure reading. Many people are walking out there with blood pressure readings that are high without the knowledge of it, because hypertension is largely a silent disease. So yes, it is important for people to have screening done, at least even twice a year. Do your blood pressure, do your sugars, and this is done all over. So people should actually go to the clinics near them. For those who come to AR, that is done every other time. So we encourage them to do that. So to answer your question, yes, we have heredity as one of the risk factors.